Good morning. It is Friday the 18th at 9:31 a.m. The scheduled session was at 9 o'clock today. I kind of hung out until about 9:30 here and then closed the room to start the recording because at this point I have to get it recorded as I have a meeting coming up at around 10:30, 11. So this will be the recording for the session. I sincerely apologize that no one attended. I can understand. I guess frustrations are high right now. So let me just kind of cover the topics that we wanted to be covered. And then also I'm going to include with the link to this video, the schedule for next week for individual meetings. Again, not necessarily to totally discuss every problem that you're having with the NPTAE or anything like that. It is to touch base. It is also to see who and when wants a PEEP so we can order those. So that will be next week. Tuesday and Wednesday are the preferred days. If somebody has a problem with those days, they need to contact either myself or Dr. O'Neill separately so that we can schedule something outside of the hours that we have available. As again, Dr. O'Neill and I are both currently in semester, so we've kind of scheduled these around our classes. So let's get started with today's review session. So today's topics requested were arterial blood gases, open kinetic chain versus closed kinetic chain, incontinence, cranial nerves, brain lobes, which kind of ties into cranial nerves, post-surgical precautions, joint mobes, and postural drainage. So with arterial blood gases, there's a lot that you could memorize when you're going down that. Arterial blood gases also includes the blood counts, the CBCs, the complete blood counts. That being said, you don't have to memorize everything. And you want to group it, like I said, into chunks that are easy to remember. So SpO2, ideal is 98 to 100%. We've known that, right? Less than 88% that will require supplemental oxygen, which does require a prescription. Less than 80% typically means no therapy. In some hospitals, it's less than 75%, but usually less than 80% means the patient is not getting enough blood to their extremities. They should not do therapy. The PaO and the PaCO2, those are the partial pressures of oxygen in the blood themselves, and it's measured in millimeters mercury. Good news is PaO, or actually technically it should be PaO2, I apologize, coincides with SpO2. Should be about 90 to 100 millimeters of mercury. That ties to 90 to 100%. PaCO2. This will affect your blood pH. If it's too high or too low, it will throw off your pH. Ideally, what I remember about that is if PaO is supposed to be 100 millimeters, PaCO is supposed to be half of that. So less than 50 millimeters of mercury. The pH, which is helped regulated by both your kidneys and primarily your lungs, the normal is 7.3 to 7.45. I remember 7.4 because that's right in the middle. Makes sense to me. Less than 7.3, you're going to acidosis because you're going more acid-like. Greater than 7.5, again, greater than 8 is basic, right? Greater than 7.5 is alkalosis, or your blood is too basic. So what I'm saying is that if you go greater than 7.5, you're just more basic than you really are. Red blood cell counts. This is just the total amount of red blood cells in the body, right? And it's going to be measured in ultraliters, I think is the term, microliters. That's what it is. Excuse me. So it's 4.5 times 10 to the 6th. Wow, that's a lot. I just remember 4.5. That helps me. But tied into RBC, not to be confused with RBG, RBG, is hematocrit and hemoglobin, HCT and HCB. These are more important to remember. So if I'm going to remember these are the ones I'm remembering. HCT should be greater than 40%, and HCB should be greater than 13 grams per deciliter. White blood cell count, I remember 4.5 to 10K. That's what I remember it. I don't remember 4,500 to, 10,000. I just remember 4.5 to 10. Low numbers can be, low or high can be indicative of leukemia, right? So they may be asking you about what type of cancer the patient has, and it's going to be tied to the white blood cell counts. or high numbers indicate an autoimmune or infectious response. Platelets, which are going to help with the PTT and the INR at the bottom. Platelets should be between 150 and 450 cells per millimeter squared. So I remember 150 to 450 for that one. And again, K, that means hundreds of thousands, right? 150,000 to 450,000. PTT or prothrombin time, you won't necessarily have a question specifically on the numbers of this, but you do need to understand that both PTT and INR ties into blood clot, right? Specifically INR, a higher number indicates chance for extreme blood clots like DVTs. Low number means patient can bleed out. That's kind of the idea. Those are the ones, if I had to, between now and test day, study. Those are the ones I'm studying. Not focusing on the rest because there's no way you're going to remember every single thing on that kind of blood gases sheet. Those are the ones I'm hitting. Those are the ones I'm studying. Anything else, I will just have to guess for if I get it. Open kinetic chain versus closed kinetic chain, right? So closed kinetic chain, the distal end is fixed, proximal segment moves, the force is applied, is not enough to overcome the resistance from the loads. The goal is to kind of, in that case, stand up, right? That's a closed kinetic chain. Open kinetic chain, the distal segment is free to move, the proximal segment's fixed, force applied is need to overcome the resistance of load. So basically, when you are doing open versus closed kinetic chain, right? A push-up, when your hands are on the ground, that would be a closed kinetic chain activity because your distal end, your hands are fixed. A curl, or in this case, since we did push-up and overhead press, would be an open kinetic chain because your distal ends are movable. What type of question would they ask on these? Because this was the question I got. If you get an open kinetic chain question or a closed kinetic chain question, they are going to be asking about roll, spin, glide. So the arthrokinematics of the joint. That is where you need to remember your convex versus concave rule, right? So if it's a convex surface moving on a concave surface, right? That means that they're going to be moving in opposite directions. If it is a concave moving on a convex, remember that we always should put one direction in a cave because they suck. So in concave, they are one direction, meaning if I roll inferiorly, it glides inferiorly. If I roll posteriorly, it glides posteriorly. In concave on convex. If it's vex on cave, then it's opposite. So if I rolls anteriorly, it glides posteriorly. So that's what the type of questions are going to ask about OCK versus CKSA. Yeah, closed kinetic versus open kinetic chain. The only other thing they could possibly ask is, you know, they give you an exercise and ask you if it's open or kinetic, closed kinetic chain. And at that point, you just have to do the exercise. There's no other way about it. You know, they're not going to give you something obscure like a German half somersault twist with, I don't know, curly fries with it. I don't know. They're going to give you something simple like a push-up, stand up from a chair, open or long arc quads, short arc quads, curls, bench press, something like that. They're not going to be giving you something that's, you know, they're not going to be giving like clean and jerk or something like that. Because again, most of the therapy we do is safety-based. We're not going to be doing a lot of those in a safety-based world. Next topic, incontinence. Well, this is kind of a topic that, you know, if we don't cover really quick, can get wet really quick. It's not a funny topic. It really isn't. There are a couple of main types of incontinence. There's stress, there's urge, there's mixed, and there's functional. The most common type of incontinence we'll get are either stress or urge. Okay, so stress is small amounts of Small amounts of urine will leak from the bladder when there's increased pressure on the bladder. Usually results from weakness of the pelvic floor. So that would be patients that we're going to do Kegels with, right? Can happen with laughing, sneezing, coughing, exercise such as lifting. Women typically with stress incontinence have underactive pelvic floor muscles. which typically gets worse post-childbirth and post-menopause. So stress incontinence is when the pelvic floor is not strong enough to hold the bladder. The bladder fills up a little bit and you giggle, and when you giggle, you tickle or tinkle, right? A lot of it has to do with sneezing and coughing or sports, right? So if you're a young female or young male doing gymnastics or I think dance, there we go, there's another one, especially, you know, the specific exercises where you're stretching, so you're stretching out the pelvic floor rather than strengthening, stress incontinence kicks in. Urge incontinence is where your bladder muscle goes into a spasm. The spasm is severe enough, medium to large amounts of urine will leak. So usually stress incontinence, petit peu, small amounts of urine. Urge incontinence is large incontinence, right? Urine's going to leak. May happen occasionally, but it may occur as often as 15 to 20 minutes. This may or may not be a pelvic floor issue. A lot of times it's not. A lot of times the patient just has a spastic bladder. You know, by spastic bladder, I mean just one of those that, for whatever reason, it goes into a spasm, starts spasming, right? So if this is my bladder, starts filling up, and all of a sudden just goes, spasms out and just dumps. A lot of times the patient only has minute amounts of warning before the urge incontinence dumps. So these patients typically do have to wear briefs or something of the sort. And it is going to be large amounts. This is not like, you know, enough that you could just put a small pad in and protect yourself. This is like full on pee, folks. Research is starting to show with this type of incontinence, urge incontinence, it may be a central sensitization issue, meaning it may have to do more with the central nervous system and overreaction of the central nervous system than it might have to do with the bladder itself. Although the bladder itself obviously plays into play if it's a central sensitization issue, that type of a thing. So with urge incontinence, you know, a lot of that's going to be desensitized in the bladder, and teaching the patient control over their bladder. Mixed is probably the worst one to have. That's a mix of both stress and urge incontinence. And the last type is functional incontinence. This is what patients like Parkinson's may have. And this, they may have some of the other ones as well, but this is because they can't get to the bathroom in time to empty their bladder. So they get up to go to the bathroom and they're getting up so slowly, they go to the bathroom, right? Or for whatever reason, their bathroom is halfway across the, you know, they live in a mansion, right? They live with Bruce Wayne. And the only bathroom's on the 4th floor of the Wayne Mansion. And they're on the 1st floor. And they move really slow. That would be a functional incontinence issue. Or, you know, it can happen to even you guys, well, healthy people, when you're driving down the road and you're like, I can hold it for the next rest stop. And you're driving along, you're like, where's the next rest stop? Right? You're driving through Montana and you're like, where's the next rest stop? Where's the next rest stop? And you don't stop to take the call of nature. Eventually, your bladder is just going to empty. And that would be a functional incontinence issue. You haven't gotten to the bathroom in time. So those are all that's what you need to know about incontinence, right? So again, stress, pelvic floor, strengthening pelvic floor. Urge, teach to control the bladder, work on if it's a central sensitization issue. Mixed, combination. And then functional, we have to make adaptations to them, maybe getting them a potty chair, maybe making sure that their chair that they sit in is closer to the bathroom, those type things, because it's not necessarily the bladder that's the problem there, it's that they can't get to the bathroom in time. Cranial nerves, reviewing these are all considered part of the CNS, right? Terminal, which your book won't, your boards won't talk about, but I added there, is a sensory, olfactory, sensory nerve, smell, right? First, you smell the cinnamon buns. Next, you look for the cinnamon buns, optic. Ocular motor, you lock onto the cinnamon buns. Trochlear, your eyes go wonkies. Ooh, cinnamon buns, right? Trigeminal. Now you're starting to look around, you get a little bit more of that sniff. Face is starting to perk up. Abducens, your eyes abduct, right? Because trochlear in, abducens out. Facial, start smiling because they're cinnamon buns. Vestibular cochlear, you might get a little dizzy because they're cinnamon buns, or you might listen to the guy as he's asking what you want to order. Glossopharyngeal, right? You start a little bit salivating, the tongue in the throat. Vagus, your heart rate goes up. Oh, I'm getting a cinnamon bun. Accessory, start shrugging. And then hypoglossal, you eat your cinnamon bun because you put it on your tongue and gone. That's the way I remember those. It all relates back to cinnamon because to me, cinnamon buns are an olfactory scent that you can definitely find out. All of those are going to come from specific parts of the brain that tie to the brain lobes, right? So that's going to come up in a little bit. You do have to know what the numbers are. You do have to know them in order, and you do have to know if they're sensory, motor, or both, right? So the brain lobes, traditionally, each of the hemispheres is divided into 4 lobes: frontal, parietal, temporal, and occipital, right? We know the frontal lobe is higher executive functions, including emotional regulation, planning, reasoning, problem solving. That's up here. You had damage to that. Typically, you have impulse control problems. This is going to tie into traumatic brain injuries and strokes, right? If you can memorize these, it can help you identify what the patient is going to look like if they have a traumatic brain injury or a stroke. Parietal lobe, integrating sensory information, including touch, temperature, pressure, and pain. Temporal lobe, temples. Processing sensory information, particularly important for hearing, makes sense. The ears are right below it. Recognizing language, which is part of hearing. And forming memories. Right now, I have a bad memory about this lecture. You have the auditory cortex, processing auditory information, visual cortex, processing visual information, and then memory, closer to the middle of the brain and close to the hippocampus, right? That's temporal lobe. Occipital lobe, smacked in the back of the head, your vision goes, right? It's the Gibbs lobe from NCIS where he smacks everybody. It's the primary visual cortex processing area, right? There is some visual processing that occurs in temporal, but the visual cortex receiving the information, sending it out to the processing in the temporal lobe occurs in the occipital, the posterior lobe. Depth perception, distance, location, identify an objects, right? Anything that you see, if you're going, oh, well, that looks like a stress ball. If you can't identify it, it's probably an occipital lobe issue. Or it could be a memory issue too, it could be hippocampal. So here's all those parts again, right? We have the forebrain, proencephalon, right? The mesencephalon, midbrain, and rhombencephalon, the hindbrain. The forebrain is divided into the telencephalon and the diencephalon, right? So the forebrain is going to have the frontal lobe, parietal lobe, occipital lobe, temporal lobe. It is also going to have the thalamus, hypothalamus, and pineal glands. The midbrain is going to have the tectum, the cerebropeduncle, and the substantia nigra. So that means it's going to have part of the cerebellum, right? And the cerebrum. The hindbrain is our base, right? It's all about the base, no treble. That's our pons and most of our cerebellum, right? Substantia nigra is kind of up there. It's also our medulla oblongata, which controls some of our, that's what alligators are ornery. They don't have medulla oblongata, right? Just kidding. They probably do have them. I don't know. Possibly. Maybe they don't. Who knows? Maybe Waterboy was right. So again, if you have a visual, right? Let's go back here. If you have a visual function, optic nerve is probably going to go back to the visual cortex, right? Most of your movement, right, is typically up here in the back of the frontal lobe and kind of going into that parietal lobe. So your movement nerves stem from there. Your hearing and balance, it's going to come from the temporal lobe. If it's something like vagus that controls a lot of your autonomic nervous system, that's going to come from your brain stem. So all of those cranial nerves stem from very specific parts, but by looking at those cranial nerves, you should be able to reasonably identify where they come from in the brain. You don't have to study something. I mean, if you want to go study specifically where those come from, great, go do that. But to me, I don't know, maybe I'm broken, but to me, it makes sense that the optic nerve comes from the occipital lobe, or at least feeds the occipital lobe. If that's probably a better term, right? Because it's a sensory nerve. We've got motor, it might stem from. So those type of things occur. And does that mean that something like a vestibular cochlear, which has hearing but also balance, has some branches coming from both lobes? Absolutely. Yeah, they can come from multiple lobes. Cranial nerves are kind of not as exclusive as something like a C5. Right? But even C5 eventually goes out to the brachial plexus and innervates a couple different places. So I hope that kind of makes a little bit more sense then. Post-surgical precautions, this one was asked for as well. The three main post-surgical precautions you have to worry about are the total hips, the low back, and the cervical. I would add also cardiac precautions in there, but those aren't necessarily post-surgical, right? So total hip replacement, we've got a posterior approach, no flexion past 90 degrees, no internal rotation, no adduction. For anterior approach or anterior lateral, depending upon the way they look at it, no hip extension past neutral, no external rotation, no abduction. So they are opposite of each other. If one asks you about the posterior or one asks you about the anterior approach, they're going to be opposite. They're not going to ask you about the no surgical precautions one because that would be silly. What are the precautions for somebody that has a pure lateral? None, unless the doc says so. Ultimately, how long do those surgical precautions last? For all of these, until the doc says so. We don't decide that. The PT may if the doc hasn't made a decision on it, but that's the PT. That is not the PTA. Our answer is until the doctor says you do not need to perform these precautions. That is how long you have to maintain these precautions. Well, you said 6 to 8 months. Great. When you go back in 6 to 8 months, he will let you know when he does not have to. You do not have to feel that he does not feel you have to do these precautions. Low back and cervical have both the same precautions. The BLT sandwich, no bending, no lifting, no twisting. With low back, it's no trunk flexion past 90 degrees, which looks a lot like no hip flexion past 90 degrees. No lifting greater than 10 pounds or a gallon of milk or a small cat. No trunk twisting, and definitely none of the three combined. Same thing with like the other hip precautions. You definitely just don't want to do them all combined. That is a recipe for disaster. Cervical surgery, no cervical flexion past 75 degrees. No lifting greater than 10 pounds, a gallon of milk, or a really small cat. And no cervical rotation or side bending as well. You could add in there, but honestly, with a cervical surgery, you're not going to side bend. Trust me, I speak from experience. The good news with the low back surgeries and cervical surgeries versus the total hip replacements is that most of them are going to have braces that prevent them from doing those. The total hip replacement will not have a brace, and we will constantly have to remind the patient. Like I said, the only caveat to that, which I was going to mention, is potentially if it is my gosh, what was I saying? Oh, cardiac precaution. Oh, that's way too big. That was not what I wanted. A cardiac precaution, right? Again, that's not considered a true post-surgical precaution. This is more of a patient that's had open heart surgery or something like that, or chest surgery, right? No sitting in the front seat of the car. That's the big one for this. No front seats. Why no front seats? Well, because the front seat has an airbag. Any of you that have been hit with that airbag, you know it sucks. I swear to God, that was the hardest I've ever been hit, and I was in fighting competitions. So no frontal airbag impacts. If your vehicle has a switch that turns off the passenger side airbag, like my truck does, I can put key in, turn it, and it turns off my passenger side airbag, then that is acceptable. Even then, I still would probably put the person in the back seat. Right? So no sitting in the front seat because of that airbag. Because when that airbag hits their chest, it's going to cause some major damage. Splint while coughing. Well, coughing / sneezing, right? You learn this with Dr. A. So if a patient suddenly has to cough, they need to grab their Huggy Buddy, their pillow, squeeze it, and close off the chest. They need to protract and kind of internally rotate their shoulders. And why is that? What we're trying to do is bring that incision site closer together, because If I cough while I'm out here, oh, even that kind of strains my chest when I'm way out like that. So splinting while coughing. There'll also be dietary restrictions of patients that have cardiac precautions, and we're not even getting into if they have chest tubes or not, because those could add all kinds of precautions with it. They may want to avoid going to comedy clubs or stuff like that, because laughing is going to hurt. That's the type of things. The main idea of cardiac precautions is knowing your vital signs, right? So they should be monitoring their vital signs at all times. But those are the main ones with cardiac precautions that I can think of right now. Joint mobilizations, real brief, just because I don't want to go over this too much. There are manual therapy techniques used to modulate pain and treat joint impairments that limit range of motion, specifically by addressing the altered mechanics of the joint. And the evidence, it is very little literature on this, and it is very mixed. It's usually case studies or small cohort studies. Why is there little in the way of randomized control trial? Because try finding 7 people or 8 people, let alone 100 people that have the same frozen shoulder. It just doesn't happen. This is where clinical experience does come into play. I have had great results with joint mobilizations, therefore I do joint mobilizations. When you hear glide or you hear manipulation, those are synonymous with mobilizations. But in Nevada, as it says at the bottom, we do not use the term manipulation because the Board of Chiropractic will have our butts. So we do mobilizations or we do glides. We do not talk about manipulations, right? We can also do compression or traction and distraction along with those mobilizations. The key thing here is, in order to do joint mobilization, the patient must be in a capsular pattern, which means you have to know your capsular patterns. If the patient has a capsular pattern, that is good for joint mobilization. Patient safety should always be considered first. If they're in early signs of trauma, maybe don't do it, especially if they're immobilized. Just saying. We need the joint to have some motion in order to mobilize. Pain is a good indication for joint mobilizations in the early stages of tissue healing. So in that kind of that emergent care position, right? Mobilization is warranted to stress and remodel scars. Absolute contraindications: osteoporosis, meaning severe osteoporosis in the area where you are doing joint mobilizations. RA, joint hypermobility, neurological symptoms, and something like a pregnant woman that has a lot of relaxing free, so late semester pregnancies. It's good for pain, muscle guarding, and spasm. There are some neurophysiological effects. There's some mechanical effects. It does help to reverse or help with reversible hypomobility, progressive limitations. May help with positional faults. So if my shoulder slightly subluxes inferiorly, a superior joint mobilization may help pop it kind of back into place. Again, pop is a relative term. I'm not saying we're doing a grade 5 here. And it may help with functional immobility. So here's that grading pattern, right? Grade 1 and 4s are our small amplitudes. Grade 2s and 3s are our large amplitudes. Get my pillow here. First thing you need to do, figure out how much range you have. So you need to take it the full way until you get to tissue tension and then back off. Tissue rebound. If you're doing a grade 1, it is a small amplitude or an oscillation at the very beginning of the range of motion. A grade 2 is going to go from 0% to 50% and back out. A grade 3, we're going to go to 50%, start there, and go 50 to 100. Grade 4, we are going to go to that 100%, and we're going to oscillate there. And then grade 5 is PT only. That's the thrust maneuver, or high velocity thrust mobilization. Those are good for snapping small adhesions, repositioning joint surfaces, all those fun things. We do not do them. It's PTA, we do not do grade 5 mobilizations. Let me repeat that. As a PTA, we do not do grade 5 mobilizations. The PTA also says we don't do any joint mobilizations. And we say, you're right. But you need to know these didactically, if nothing else. Lung butter or postural drainage. What you need to know about this, that is mainly taken over by RT in the real world, but we typically only do this with children with cystic fibrosis, or in the case right now of COVID. This is important for you to understand, but again, there may be one, maybe two questions. There's not gonna be a ton of questions on this. So I know that you guys are focusing on this, but it's because it's an obscure topic. And you're like, oh my God, what if I get 15 questions on this? You won't. This is an obscure topic. You might get one, right? And most of the time it's going to be on something like, why am I doing this? Well, I'm trying to get the gunk out of the lungs. Remember, there are a couple things to think about. Fremitus. Fremitus is that sign where you place your hands on their back and you measure the vibration of the lungs, typically by having them repeat 99, the sound, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. And you're detecting, is the vibration equal throughout the whole chest and the whole back? Percussion is where we're beating, right? Vibration, vibrating. When we do clearing the lungs or get rid of the lung butter, we are going to check the amount, the color, consistency, and smell of the lung butter. That being said, let's look at this. So posture drainage work better working with the active cycle of breathing. Remember the cycle of breathing. We have diaphragmatic breathing first, teaching to breathe the belly, right? Then we have lateral expansion, right? And then we have what's known as forced expiration, getting the lung butter out. Every position you put the patient in, every position you do drainage, you are going to then go through all three of those cycles again after you've completed a clearance. So diaphragmatic breathing, lateral expansion, cough it up. Means before you ever teach or do posture drainage, patient must understand the active cycle of breathing. It can be done either via gravity, which is postural drainage purely, or percussive postural drainage, which is the most common. But all of those are going to work on the gravitational concept. You're going to put the patient in a position where that lung lobe drains into the main bronchioles. That's kind of the idea and the goal, is to put that lung in line, right, with the bronchioles. So if I'm looking at my lower lung, I want to get at the point where gravity is causing that lung to drain into my bronchioles. That's the main idea. So this is looking at those lobes, right? Remember that on the right side, we do not have a middle lobe because of the cardiac notch where the heart is. This is a really kind of good form for that. There's got to be your rehab book talking about how to drain each of those. And if you look at these, this just is self-explanatory, right? If I'm doing the upper lobes, I kind of have him posterior leaning so that these lobes drain into that. Oh, that was white. That's not very good. But these lobes drain into the main bronchiole so that they can cough them up. That is the idea of postural and percussive drainage. Most of your percussive drainage will be done in Trendelenburg, leg up position. Some of it is done in the seated position, most notably the anteriors and apical segments. So for the most part, again, you are going to do them in Trendelenburg position to allow gravity to clear the lungs. The patient can do postural drainage on their own when they get home by positioning themselves in these positions and not having any percussive done at all. So if you have patients got a lot of lung butter down in like the lateral basal segment of the lungs, right? They can lay sideline with that one arm up and over and then elevate themselves so they're laying at an angle. That would be postural drainage. Percussive is going to be when we come in and we beat on that exact red area on the body that's displayed there. Hope that kind of clears that up. The other thing I did have somebody ask me about again was the gait cycle and muscle activity during gait. What I'm going to refer you to is the last session I did, which would be the session for, what session was that? Let me look here real quick. Actually, it was 521. On 521, I have covered the muscle action during gait. I have this PowerPoint that I created for that, which talks about every single thing. So here we start with muscle action during gait that goes through initial contact, loading response, mid stance, mid swing. That being said, you can memorize all of this. Just do the motion. You can pretty much solve the question if you do the motion yourself. If you need to do a heel strike, put your heel down under your table and go, oh, well, there's going to be an eccentric portion of that because I'm going to be slow on the leg down as it strikes, right? Your dorsiflexors are pulling your toes up, and they're going to be going from pulling up to an isometric hold to allowing an eccentric drop of the foot. Don't get overloaded with having to memorize this stuff. Do it. You can't get up during your test, right? You can't get up and walk around the room. They'll yell at you. So just do it under your desk. Think about where I'm going to be at mid stance, right? Mid stance, I'm pretty much, right? But, you know, when I'm at mid stance, most of the stuff is going to be doing some concentric and eccentric work. Right? Just think, is the muscle at this point slowing something down? If it is, it's eccentric. Is it holding it in the case of immediately after heel strike? Is that dorsiflexor holding that initial contact, right? Dorsiflexor is maintaining a neutral position of the ankle. That means it's isometrically holding it in place, right? Or is it pushing off, right? In the case of something like a swing phase, where you start that swing phase when you go into pre-swing and the hip flexors are starting to pull that leg through concentrically. Think logically through it and do the motion. Can you memorize all this stuff? Absolutely. You can memorize it by next month, right? But I guarantee you're going to kind of mess it up. Just guarantee it. Do the motion and think through it. You guys know what an eccentric control is. You know what a concentric control is. You know what an isometric hold is. Think that way. Don't, I know I sound like I don't know, sound like a broken record here a little bit, or I sound like a know-it-all. You should know this. But in this case, you really should. This is like the basics of everything. You should really be able to identify what is an eccentric activity versus a concentric activity versus an isometric activity. I mean, I can't really help you there if you don't know the basics of isometrics versus concentric, or isotonics versus isometrics, right? It's because isotonics include both concentric and eccentric motion. So think through it logically. Don't allow your brain to overthink the obvious, right? Don't allow that to happen. So I hope that has helped everybody. That was all the topics I had on my list for today. So if there is anything else, please let me know. We'll have another session next week at 9 a.m. like this was. If you need anything before then, please contact me. I know that I've had a couple people text me last night. Unfortunately, if you text me last night, there was no way I was going to work something in today. Just wasn't happening. Didn't have time. Sorry, I was not staying up to 1 o'clock working on something. If there are any other questions, please message me. If there's any concern, please message me or Dr. O'Neill. We want to help you. We want to make sure you pass the boards, right? So please do that. If there's any questions, concerns, comments, even if you want to yell into the void, please call me, contact me, whatever you may be. Other than that, like Picard said, make it so, and I will see you on the next one. Included with this, like I said, I will include the sheet for signing up. Let me just bring that up real quick just so you can see what it kind of looks like. So this is the kind of individual meeting sheet that you guys will receive from us that has sign-up times for Tuesday and Wednesday. Again, if there's something outside of those sign-up times, you're just going to come in here and you're going to put your name in here. My name is Mud. Don't put my name as Mud. I still don't know who you are. But just put your name in there, be done with it, and I will see you next week. Thank you very much. It's been a pleasure talking to you all or talking at you guys. Have a great weekend. Have fun. Do whatever. I will talk to you on the flip side. And like the trash, I'm on Thursday. I am out.